Hi, I'm Dr. Jack West, and I'm an associate clinical professor in medical oncology at the City of Hope Comprehensive Cancer Center in the Los Angeles area. The PACIFIC trial in stage 3 non-small lung cancer that is unresectable has really completely redefined what we consider the standard of care for this setting. And now we would be inclined to give concurrent chemoradiation, which can potentially be preceded by induction chemotherapy alone. That was done in about 20 to 25% of the patients on the study. But in any event, we are inclined to get through the chemoradiation portion and then transition to consolidation durvalumab for about a year. Importantly, a lot of patients do not get through that full year for one reason or another. It may be progression of disease, it may be toleration issues, it may be just wanting to stop. But in any event, the question has now come up of what do you do if someone demonstrates progression in that setting? And I would distinguish between the separate issues of what if they're progressing on durvalumab and what if they're progressing after they've completed the duration of durvalumab, whether that is due to side effect issues or just having completed a year. If someone has progressed while they're on durvalumab, I would really consider this to be very similar to the setting of someone progressing on first-line pembrolizumab for, say, high PD-L1. In that setting, they have demonstrated that they've got acquired resistance to immunotherapy. I would have really no enthusiasm for further immunotherapy, but I would be inclined to return to a chemotherapy approach. These patients will most of the time have had just a couple of cycles of chemotherapy, and I would say that they have not necessarily or even likely exhausted the benefit of platinum doublet chemotherapy. That would be especially true if they just got 6 or 7 weeks of low-dose weekly carbopaclitaxel, which does not have much systemic efficacy. So I would consider these people to be, if not chemotherapy naive, at least kind of chemotherapy undertreated, and still with potential benefit from a chemotherapy-based approach, but having exhausted the benefit of immunotherapy. And I would return to whatever chemotherapy backbone I think could best benefit that patient. So it might be a carbopemetrexid-based approach for someone with an adenocarcinoma or non-squam, and a carbo and taxane or gemcitabine, if you prefer, for someone with squamous histology, dealer's choice. Now, in somebody who progresses after they have come off of durvalumab, it would depend on why they came off. If they had terrible toxicity, I would not go back to immunotherapy, and I would approach those like the patients I just discussed, someone who's really not a candidate for further chemo because they had grade 4 hepatitis or severe pneumonitis or something. But if they stopped because they completed a year and then 4 or 6 months later had progression of their disease, or if they stopped because they had renal insufficiency and it was a judgment call, stopped because their creatinine had risen and now it's normalized, I would be inclined to re-challenge these people with durvalumab or potentially switch to an agent like pembrolizumab if you knew that they were PD-L1 positive or especially high PD-L1. So I don't think there's any reason that we could distinguish between durvalumab versus another. I think that's really just a dealer's choice. But I would be inclined to go back to immunotherapy if the patient had not progressed while they were on immunotherapy.